we're going to, the first thing we need to do is enter the patient's data into the machine. So we press the patient button. We need to create a patient. On this unit, the set button is your enter. It's equivalent to the left mouse click. Set. It brings up our demographic screen. We put in our patient ID, name, last name. Oops. And for Medicare, you do need a date of birth. Okay. And people ask that every day. Once everything looks complete, we are finished, and we're going to create the patient and exit by pushing the patient button again. Now, if you look in the corner, you see there's our patient name with our identification number. Okay. If it's done correctly, that will appear. If you've messed something up, it won't be there. Okay. We're first going to look at a shoulder. So we go down to the next button under patient, and it says application. Press here. Which probe for the shoulder you'd like to use, the 12 linear probe. We're going to press set again. It'll bring up different options. Under the MSK option, we're going to find shoulder. Now the machine goes to its preset for the shoulder examination. The notch, or the keel, the small button, is going to be placed towards the midline of the patient in the first scan. Okay, so we're going to do the transverse biceps tendon, just pushing the probe onto the skin at the biceps interval. So there we are. This is the transverse biceps tendon picture. Okay. I'm going to save the image, so press freeze, and then we want to save, which is the store button, and then there's a thumbnail of the image that we just created. So that's scan number 1, transverse biceps. So here we are scanning our biceps tendon, and we have a nice patient here. The anatomy comes through pretty clearly. But let's suppose we had a large patient with a lot of mass on their shoulder. One thing we might want to do to enhance the image is change the frequency. If you look on the bottom of the screen, we have different options. You may notice the second one is frequency. We can take the frequency down by pressing on the left key. That's going to lower our frequency. And for a large patient, this is ideal because the ultrasound beam is going to penetrate now. Actually, the image is going to penetrate deeper. So now we're at 7.5 megahertz. Whereas our preset was at 10.5 megahertz. Another thing we might want to do is change the focus number and the focus position. The first key here is focus position. If you see the caret here, that is where the image is optimized by the ultrasound machine. Coming down here, we see the caret corresponds with these soft keys. By pushing the negative sign, we actually decrease the depth of the caret. Positive sign will increase the depth of the caret. So now our optimum image now is at 3 centimeters, which for a large patient might be more appropriate than the 2 that we were initially set at. If you look at this image and you can't see much contrast between the image, one thing you may want to do is adjust the acoustic power. Soft kiss you can. So we come down to acoustic power at 100%. What acoustic power is, that's the amount of whiteness that the machine generates. So if I decrease our acoustic power, it's going to be less harsh to the eyes. One thing you may notice that's happening is now we increase our contrast. Now we can actually see fluid in the biceps tendon, whereas at the preset of 100, it was very difficult to appreciate that fluid there. So what's happening is we didn't have enough difference between the whites and the blacks to make a noticeable change. My personal preference is not the manufacturer's suggestion. I like the acoustic power closer to 45 to 50 rather than 100 as on the preset, and this is the reason why. Now I can clearly make out the boundaries of the biceps tendon, which is the brighter structure, and I can actually see fluid in the bicipital groove, which I could not do at the manufacturer preset. Your body. Okay, it's like shooting a gun. Okay, if your sights don't line up, you have a sight here and a sight here, and you're looking like this, it's worthless. Okay? You need your sights to line up. Same as shooting a gun. There's my finger depressing the tissue right there on the screen. I'll successfully get the needle and I'll be able to see it. Okay? If you attempted doing this, you will fail most of the time. Every time I turn my head to see the screen, I won't see the needle. I'll look back down here, start fiddling around. The patient will see, I see it. You look, your hand moves, you will not see it. You have to be able to see everything at the same time, or you'll most likely fail. So to do the joint injection, rather than using the linear probe, which we were scanning with, I would rather use the curvilinear probe. So let's go ahead and change that. So I'm going to press the application feature, and I'm going to go to the 2C5 probe, which is our curvilinear, and we're going to come up with different joints here to choose as well. I'll choose the shoulder under the curvilinear function.
And Michael, why do you like the other probe?
The reason being, the curvilinear array. As you can see, I'll put a little gel on here. You actually see that your beam width is expanding. So ultrasound beams are coming out not just linear, but they're coming out at a convex angle. It allows you to capture the needle quicker. It allows you to actually inject at a steeper angle. To capture a needle with a linear probe, you have to go at a fairly shallow angle to the skin. With this probe, you can actually go at a much steeper angle. Okay. That's why I like it. So again, I'm going to adjust the acoustic power one more time. So we'll take the acoustic power down to about 45. Okay. So for this injection, again, I'm going to put the notch towards the midline. So, the notch to the midline. Come over here for just a second. The appropriate way to do this is you palpate the soft spot in the shoulder. So here's our spine of the scapula. We can palpate the spine. Here's our humeral head, and we palpate the soft spot right here. What I'm going to do, keeping my finger on the soft spot, I'm going to put the probe right on top of it. Okay. Let's freeze it right there so you can get a picture on the screen. By placing my probe on the soft spot, I can now identify the humeral head and the glenoid, and there's a dark stripe in between. That is our joint. Okay. So to prove that point, let me show you with a video sequence. Okay. So here we are. Here's our humeral head. Here's our glenoid. So I'm going to take the patient's arm and externally rotate. You can see the humeral head rotating under the glenoid. So let's freeze that for just a second. So what do we have here anatomically? Go back just a second. Okay. So we have glenoid bone, which comes up. This white triangle that you can see through, that's your posterior labrum. And then we have our humeral head. The appropriate place to put your needle for this is between your labrum and the humeral head.
Okay.
12 megahertz probe in MSK setting. And select elbow. So again, I'm going to drop the acoustic power, which is the last soft key, bottom function. And I'll take that down to about 41. Okay. So the lateral epicondyle. So very simply, and if you zoom in with the camera, hopefully you can see this bony ridge right here.
Yes.
That's called the lateral epicondyle. Okay. If you can see it, if you can feel it, you can find it with the ultrasound. What you're going to want to do is put the edge of the ultrasound probe right on the epicondyle and have the other end projecting towards the middle knuckle of the hand, just like that. And if you look on the screen, there's the lateral epicondyle, and here's our common extensor tendon, coming in and attaching onto the bone. Here's our joint space. This is radial head. This is lateral epicondyle. So if you want to see the radial head, we can actually rotate it. And you can see the rotation of the radial head right there as we rotate the wrist.
Perfect.
So where the lateral epicondyle, where the common extensor tendon comes in and attaches onto the epicondyle, that's where people get epicondylitis.
Okay.
So the injection for the lateral epicondyle, there's many ways to do it. You can do it the classic way, where you guide the needle from distal to proximal along the top of the epicondyle and inject. Okay. Now, because you have an ultrasound and you can see it, why not make your life easier? So going all this distance, why don't we come from the back? Inject right underneath the skin, right under the probe, make sure everything lines up again. You want to inject right into under the skin. It's very superficial. You may notice this is 1 centimeter of depth, so about half a centimeter of depth. And we're going to guide our needle very shallowly right to the paratendon of the common extensor tendon. As we know from histologic experiments, most of the pathology is at the tip. The classic way, you're injecting along and under it. A lot of medication is never reaching the tip where the pathology is anyway. We come from proximal to distal, we go right to the tip and inject into the paratendon, and it will bathe the tendon. Analysis. I'm going to measure it. So I push the measure button, it brings up this crosshair. Set, drops an anchor, and set, drops an anchor. Okay. The magic number for the thickness of the lateral epicondyle is 0.4 centimeters. Anything over that is considered hypertrophic. It's hypertrophic because it has edema and mucoid deposition of the tendon. We look at our symptomatic patient, he's at 0.5. He's 1 millimeter larger than ideal. This tells us that he has a tendinosis of the common extensor tendon. And we've just verified that he has a symptomatic lateral epicondylitis.
I got the
Button, the 12.5 probe, MSK once again, and we're going to the knee. Now I'm going to point it out again, set is your enter button. I keep pressing that, but it's probably going to be forgotten rather quickly. And the first scan of the knee is the suprapatella bursa. So my notch is going to be pointed cephalad. And here is our image. So with the preset, we're not quite deep enough. So we need to increase the depth. Here's our depth button. Press up once to get a little bit deeper, up twice to make it optimal. So here's our patella, bony landmark, and this bony landmark here is our femur. So here we are in the suprapatella bursa. Let's freeze it right here. You may need to zoom in for just a second. Hopefully you can see this dark path right here. That's the suprapatellar recess. If you put the medicine there, it goes into the joint.
Okay.
So the way to do this, let me go live again. I'm going to rotate the probe over the recess 90 degrees, something like that. And hopefully everyone can see our recess, the black, that's the fluid. Okay. So real quickly, I'm going to note mentally how deep this is. Look on the side of the screen, 1 centimeter, 2 centimeters. Corresponds with the recess. Come here. From the probe, I'm going to travel 2 centimeters, which is a little bit less than an inch, down the leg. Okay. So here we are, about 2 centimeters down from the probe. Here, and I'm going to inject exactly perpendicular to the probe, and when I do this, you can actually see tissue moving. So I'm at the right depth. Where the tissue is, one tissue looks to be sliding over the other tissue. Hopefully you can see that with motion. That is the suprapatellar recess. You would like to park your needle on top of that moving space. So you want your medication to go between those two planes. If it goes between those two planes, you're in this patella recess. It will go into the knee joint. If you can take a strap, so let's start under the knee here. Some of that too dark now.
The power is 0 now.
Yeah, so now we're at 0, so this is going to be about as contrasty as you can get. So there's our patella. So I'm in for patella now. And the bone density at the bottom of the screen here, that's actually the tibial condyle. Now why is that important? You see the black sitting on top of the tibial condyle here? That's the cartilage of the condyle. That's the cartilage of the knee. So if you have a doctor that actually wants to look at cartilage, that's your view right there. So most docs are concerned about how much cartilage someone has on their femoral condyle. I think I said tibial. Right? On their femoral condyle, there's a view right there of how much cartilage someone has.
Okay.
So tracing it down. So they're on patella, femoral condyle, and we come down to the tibia. And that's the tibial insertion right there. So our patella tendon is coming across the screen and inserting onto the tibia.
Yep.
Another structure you probably want to look at is the medial meniscus. The best way to do the medial meniscus, in my opinion, is you're going to put the knee on the side, basically at the midpoint of the knee. You're going to find your little high most of the time. It's actually just a little bit below the midpoint of the knee. So if you put it on here, I can't see how you can try drawing your probe down just a little bit, it'll show up most of the time. So that's actually your medial joint line right there on the screen. And the space in between, there's a gray space in between. I think it looks kind of like an ice cream cone.
Yep.
That's your medial meniscus. The lateral meniscus, same thing. You're going to start on the midline and go down the leg. Always just a little bit lower than most people think. Same thing in the same fashion, the ice cream cone in the middle of the two bones. That is your lateral. And now label our image. So on the keys here, we're looking for the button that says text. It's right up here above the 9 key, text. And it's going to bring up a cursor, a text cursor. So we can write on here, right, elbow. If we want to put the text somewhere else, just use the trackball, move it up. This is the lateral epicondyle, so I'll put lateral epi for lateral epicondyle. And we can write over here, if you like, proximal and joint. Oops. Right. Okay, so now that you have everything labeled, we don't want that floating around on our screen, so we need to get rid of it, right? You have a couple options. On the soft key here, the middle one, there's delete text. I can push that, it's going to delete the last thing I wrote. So the word joint is going to disappear. Okay. If I want to delete everything, push the bottom one, clear screen. It elects everything you've done. Image, freeze, store. Now we want to make a report. So up here on the top row of keys, we find the report, which is over the 3 button. We press report. Our patient demographics we've already filled out. They're in here. And we can drag and drop pictures into our report. So set, drag it into the report. There it is. If we scroll down the screen, we can type in our text. So insert text. And now we can type whatever we like and the diagnosis of whatever we like.
And hit save. Is there a
And then we
save?
hit save, which is this top soft key. There's save, print, retrieve, and template. Successful. We're going to basically on the anterior lateral of the neck, above the collarbone, we'll put the probe on there, and right in the center of the screen, we can adjust the brightness. There's our carotid artery pumping away. So if we want to see it with the color, that's the jugular vein. there's our carotid artery. Now notice blue and red. Okay, which one is the artery, which one is the vein? In this instance, the artery is pumping and is blue. The vein is red. Now, why is that? Because it only has to do with which ways the blood coming from. It has nothing to do with oxygenation.
Okay.
Bundles